for the next talk, I would like to invite Dr. Marushka. She is an AIOS Prem Prakash Award and Disha Award winner. The topic she is going to talk about is third nerve palsy, medial rectus resection versus fixation to the medial palpebral ligament.
Thank you, sir.
Dr. Chenmai is there?
So we know that the surgical management of oculomotor nerve palsy is challenging. It requires meticulous surgical planning. There is no clear consensus about treatment, and long-term surgical undercorrection is common. Our aims were to compare the results of lateral rectus deactivation combined with medial rectus resection and combined lateral rectus deactivation with medial rectus fixation to the medial palpebral ligament performed in the same operative session for total oculomotor nerve palsy in terms of successful alignment and ocular morbidity. It was a retrospective analytical study carried out between Jan 2006 to June 2020 at Arvind Eye Hospital, Madurai. We had a total of 35 patients. All our patients with complete oculomotor nerve palsy with large angle exotropia, more than 50 prism diopters, underwent lateral rectus deactivation of the affected eye. In group 1, this was combined with medial rectus resection. In group 2, it was combined with MR fixation to the MPL. We included all patients with complete oculomotor nerve palsy with a follow-up of at least 6 months after diagnosis. We excluded patients who underwent prior strabismus surgery or those with neurological abnormalities. All our patients underwent a detailed ophthal evaluation, including oculomotility testing and measurement of the deviation. FDT and FGT in clinic was done for all adult patients, and intraoperative FDT was done for all patients. All patients were operated under general anesthesia by a single surgeon, and we measured the ocular deviation on postoperative day 1 and 6 months. Our success criteria was defined as horizontal deviation of less than or equal to 20 prism diopters in primary position at 6 months post-op. So for LR deactivation, after isolating the lateral rectus, we secured it with 5-0 non-absorbable polyester suture and disinserted it from the globe. A hockey stick incision was then made over the lateral orbital rim, exposing periosteum. The posterior tenons was opened, LR was retrieved and secured to the periosteum, and the posterior tenons was closed. In the first group, we combined this with 10 mm of medial rectus resection. In the second group, we combined it with medial rectus fixation to the MPL. So after identifying the medial rectus and the insertion of the medial palpebral ligament, we secured the insertion of the medial palpebral ligament with its periosteum with 5-0 polyester suture. We then threaded an empty semicircular needle through the skin, through the conjunctiva to emerge above and below the medial rectus. We passed this non-absorbable suture through the semicircular needle and secured the upper and lower pole of the medial rectus, and we fixed the eye in 10 degrees of esotropia. So we had 20 patients in our resection group, 15 in fixation group, and an age range of 3 to 65 years. If we see on post-op day 1, both groups performed excellently at correcting the exotropia, but at 6 months post-op, only 65% of group 1 as compared to 93% of group 2 were able to maintain this deviation. If we see, our results are not statistically significant. What was statistically significant is the residual exotropia at 6 months, with group 2 performing much better than group 1. We did not note any significant post-op complications in the resection group, but in the fixation group, we saw one patient who had persistent medial conjunctival congestion and a second patient who had a suture granuloma at the MR site. So these are the pre-operative and 6 months post-op pictures of LR deactivation with MR resection. And this is LR deactivation with MR fixation to the MPL. We saw that in the first group, it was a technically simple procedure. There were no important structures present laterally. Post-exotropic drift could be due to slackening of the medial rectus, and there was less severe limitation of ocular motility. In the second group, it was more difficult with extensive tissue dissection. There was poor cosmesis. Lacrimal sac and angular vessels could be injured. There was persistent epiphora and severe limitation of motility post-op. Our limitations were that randomized controlled studies would better assess the efficacy of each procedure. Post-operative drift beyond 6 months was not taken into account. The number of patients in each group were different, and due to a relatively small sample size, our results were not statistically significant. So in conclusion, we'd like to say that both techniques provide good reconstructive correction of large angle exotropia in complete oculomotor nerve palsy. But we found that lateral rectus deactivation with MPL fixation, though requiring more time and surgical expertise, prevents a long-term post-op exotropic drift better. Thank you.